Hello, everyone. My name is Laz Boris, and I'm president of the Thyroid Foundation of Canada. I'd like to welcome you to our April 30th public education webinar. Our guest speaker today is Dr. Hernan Franco Lopez, who will be speaking on Hashimoto's disease. Dr. Franco Lopez is an endocrinology fellow at Western University in London, Ontario. He completed his medical school at the University of Ottawa and his internal medicine training at McMaster University in Hamilton, Ontario. He has an interest in general endocrinology, in particular thyroid and adrenal diseases. He is also interested in medical education and health advocacy, which are important in the field of chronic disease, such as endocrinology. Once the presentation has been completed, Dr. Franco Lopez will answer questions from the audience. Catherine Keene, our administrator, will be acting as producer for this webinar. This means she will be managing the technical aspects of Zoom. Some of our board directors would also be assisting. Hanista Primachandran will be looking after the Q&A section. Laurie Martin will assist us in the chat room. This event will be recorded and made available on our website later this week. Before we begin, I'd like to go over some housekeeping. We use the webinar functionality of Zoom. This means that you can see and hear the presenter and support team, but your audio and camera are not active. Please have a look at the controls at the bottom of your Zoom screen. We're not using the raised hand feature. Please use the Q&A feature to ask your questions. You're able to communicate with other attendees using the chat feature, so please feel free to join in. If you do not wish to see the chat previews displayed at the bottom of your screen during the presentation, please click on the chat button arrow and deselect the Show Chat Previews option. If you have any technical issues during the webinar, please reach out to Catherine via the chat feature. At this point, we are ready to begin with Dr. Franco Lopez's presentation.
All right, thank you very much, Laz. I'm just going to share my screen here. Okay. All right, so good day to everyone. My name is Hernan Franco. I'm one of the endocrinologists at Western University in London, Ontario. And I want to thank the Laz and the Thyroid Foundation of Canada for inviting me to speak today about Hashimoto's thyroiditis. So we're going to get started. So first of all, just some disclosures. I don't have any conflicts of interest for this talk. This is presented more for general informational and educational purposes only. It is not meant to be medical advice, so it doesn't substitute an in-person consultation with your healthcare provider. So any specific questions about your diagnosis, treatment, and prognosis, I'll try my best to answer, but they should be better discussed with the healthcare provider. The objectives for the talk today, we want to start by defining Hashimoto thyroiditis and then provide a little bit of historical perspective on how it got its name. We'll describe the mechanism of thyroid hormone production, as well as the negative feedback that we use to control thyroid hormone production, and then compare that to what happens in Hashimoto's. We'll also review the pathophysiology of Hashimoto thyroiditis, and then list some of the known precipitating and associated factors of autoimmune thyroid disease. Then at the end, we'll discuss some basic principles of management of hypothyroidism. All right, so let's get started. So what is Hashimoto thyroiditis? So it is also known as chronic autoimmune or lymphocytic thyroiditis. It is actually the most common form of hypothyroidism in iodine-sufficient areas of the world, such as North America. However, if we look at all countries in general worldwide, iron deficiency tends to be the #1 cause of hypothyroidism in the world. Now, when we look at the North American population, about 10% of us will have the presence of thyroid antibodies, and about 5% of us will have overt hypothyroidism. And these numbers come from a large survey that was done in the United States called the National Health and Nutrition Examination Survey, where they looked at about 13,000 people that were not known to have thyroid disease and looked at some of these markers. Now, Hashimoto's tends to have a preference or prevalence in women more so than in men. And based on the literature that you read, that number could be 7 to 1 to up to 10 in 1. So this picture here is Dr. Hikaru Hashimoto. So he is a Japanese physician born in the 1880s. Out of a family of physicians in Japan, his dad was also a doctor. He graduated medical school in 1907 in Kyushu University and immediately began working at the Department of Surgery of that university. Interestingly, he examined the thyroid tissues of 4 middle-aged women at the time, and he was noting some different characteristics of these thyroid glands that were not seen before or published at least. He put all these findings together and published a paper in 1912 when he called this constellation of findings struma lymphomatosa. And interestingly, nothing really happened with that paper for about 20 years when in Cleveland, Ohio, Alan Graham published similar findings in some of the thyroid glands that he was looking at. Dr. Hashimoto passed away in 1934 from typhoid at the age of 52. And he actually didn't get recognition for Hashimoto's disease until about 20 years later in 1962, when he was finally recognized in the Lancet in a paper where they actually attributed autoimmune thyroid disease findings to Dr. Hashimoto. This here is actually the front page of that paper that he published back in 1912 in a German journal article. And then here he described 4 histological characteristics, so 4 things that he saw under the microscope. So one, he saw that the glands of these 4 women that he looked at were actually full of lymphoid follicle formation. And lymphoid essentially basically means white blood cells, so cells that we use to fight infection and produce inflammation. And he saw that there was a diffuse infiltration of these cells along the glands. This infiltration of the white blood cells then led to degeneration of the normal follicles of the thyroid gland and the epithelial cells. And then later on in the disease process led to prominent fibrosis or scarring of the thyroid gland. When we looked at what a normal thyroid gland is, we have a picture representation here on the left. So we have the thyroid gland that's in our neck. And then the thyroid gland is formed of several follicles, which are composed of cells surrounding a middle colloid, which is some fluid-filled substance that this is where our thyroid hormones are stored. And if you can see here, if I can put my cursor around the colloid, the follicles here, we also have capillaries or blood vessels that this is where we can get the thyroid hormones into our circulation. On the right here, this is actually what it looks like under a microscope. So we use different types of staining to differentiate between cells and non-cells. So here, we have the purple round circles here. Those are all nuclei of cells. And as you can see, they're very nicely organized in the circular pattern with the colloid in the middle in pink. And if we see some of the darker pink here, that's actually a capillary. So this is where we get one of the blood vessels within the thyroid. So it's a very nice, well laid out architecture in the normal thyroid gland. So how are thyroid hormones produced? So they are exclusively produced at the thyroid gland. And as we mentioned in the previous slides, the thyroid gland has the follicles with the fluid-filled colloid where the thyroid hormones are stored, and then capillaries or blood vessels where we actually secrete some of these thyroid hormones into the circulation. We know that there's 2 main thyroid hormones available, the T4 called thyroxine and T3, triiodothyronine. Now the thyroid hormones have this backbone, a protein precursor called thyroglobulin. And thyroglobulin proteins have tyrosine amino acids, which is where we actually put in our iodine molecules, either 4 or 3. And that's where we get our name T4 and T3, based on how many iodine molecules we have in our hormone. When we look at how this process happens, this is just a picture representation to simplify things for us. We have on the left our blood vessel there, and in our circulation, we have our iodine that we take in from our diet. In the middle, we have the thyroid cell, and in the right, we have the colloid, which is the middle part of those follicles. Within the colloid, we have the thyroglobulin proteins here represented in orange. And we have this enzyme here called TPO, or thyroid peroxidase, which is the enzyme that actually helps us put the thyroid hormones together. So when we need thyroid hormone, then we get some influx of iodine into the thyroid cell, and it quickly diffuses into the colloid to be able to be available for the thyroglobulin to be able to be formed. Then TPO, which is the enzyme, will take all of these things together and then form our T4 and T3, again, based on how many iodine molecules we put into each of the thyroglobulin molecules. And then when we need this hormone, then they actually get put into these little vesicles inside the cell and then excreted into the circulation to be able to be used. What happens in Hashimoto's, however, is that we have antibodies represented here by the little Y markers that attack not only the TPO enzyme, but also the thyroglobulin molecules. So we actually don't have anything to be able to for our thyroid hormones, and that's when we become hypothyroid. The ratio of thyroid hormones produced in the human thyroid is about 16:1. So we actually excrete more T4 than we do T3. And most of the thyroid hormones that are excreted into the circulation are actually bound to protein. So the thyroid binding globulin is one of the main proteins for thyroid hormone, but also albumin is used as well. That means that less than 1% of the thyroid hormone that we produce is actually in the circulation as a free hormone, which is what we measure on our blood work more commonly, free T4 and free T3. And those are the ones that are readily available for the cells to use if we need thyroid hormone. And most of the bound hormone then will be used as a reservoir. T4 is actually a prohormone. So free T4 doesn't have any metabolic activity, but it does have a long half-life. It lasts about 7 days in our bloodstream. T3, which is the active hormone, has a shorter half-life, it's less than a day. So the way that we get around to this is that T4 is actually converted to T3 inside of the cells that need it when they need it. And this is done by enzymes within the cells called deiodinases. I just put it here as a picture representation here that deiodinase 2 or D2 takes care of removing one iodine molecule from T4 and converting it into T3 within the cell. In a similar way, we have other deiodinases like D3 that take away a different iodine molecule from a different site and actually inactivate T3 from a form called reverse T3. So this is not biologically active. And this is actually a way for the cells to be able to regulate the amount of thyroid hormone that is available for them to use for metabolic activity. And as you can see in this picture here, we have the D3s and D2s within the cell, and they can actually regulate both T4 into reverse T3 or T3 to be able to be used. But they can also inactivate T3 that diffuses freely into the cell into T2 by removing an additional iodine molecule. And this is our way of the cells to kind of keep a check into how much thyroid hormone will be available for them. How do we regulate thyroid hormone production? It has to do with a negative feedback that includes not only the hypothalamus and the pituitary gland in our brain, but also our thyroid gland in our neck. Typically, when we're hypothyroid, which is the case in Hashimoto's, that basically means that our free T4 and free T3 levels are low. What this causes then is actually sends a signal to both the hypothalamus and the pituitary gland to produce TRH and TSH respectively to stimulate the thyroid gland to produce more hormone. If that's the case and we have a functional thyroid gland, then this causes the thyroid gland to produce more T4 and T3. And when things kind of regulate themselves and go back to normal, then the axis will stabilize and we go back to a baseline level of production. In Hashimoto's thyroiditis, however, we do have this signal of low T4 and T3 to both our hypothalamus and our pituitary gland. And then we can send as much TSH as we like to this thyroid gland, but because of all the damage that happens at the level of the thyroid gland, it doesn't have the ability to produce enough thyroid hormone to be able to regulate the axis. So we're in the states of permanent elevated TSH and low T4 and T3. And this is in fact what we use to interpret our blood work when we screen our patients, is that we send the TSH level. If the TSH level is high, that basically means that your T3 and T4 levels are going to be low, and we label that hypothyroidism. In those cases, then we need to provide a thyroid hormone replacement. If on the other hand, we have our TSH level that is low, that means that your T4 and T3 levels are high, and you are what we call hyperthyroid, or you have too much thyroid hormone. This can be either because you have an overactive thyroid gland that's producing too much, or if you're on thyroid replacement, maybe you're taking a little bit too much of thyroid hormone replacement. In the cases of Hashimoto, we have that first scenario where our TSH will be high and your T4 and T3 levels are going to be low. So what happens in Hashimoto? So as Dr. Hashimoto mentioned in this paper back in 1912, we actually see this white blood cell infiltration into the thyroid tissue. And white blood cells, we have two different types. We have B cells and T cells. Now, B cells are there to produce antibodies within the thyroid gland. And in Hashimoto's thyroiditis specifically, we have two main antibodies that we see. One is the thyroid peroxidase antibodies, or anti-TPO. And again, if we go back to a picture, they will be the ones that target that enzyme that couples iodine to thyroglobulin. And we also have thyroglobulin-specific antibodies, or anti-TG, and those actually target thyroglobulin directly. Now, when we look at the studies, anti-TPO seems to be more specific for Hashimoto's and progression to overt hypothyroidism, more so than thyroglobulin antibodies, but both of them are present. However, it is not only patients with Hashimoto's that have antibodies in their bloodstream. When we look at studies that screen the general population, up to 20 to 27% of people, even though they have normal thyroid function, we have some sort of antibody detected in their bloodstream. Patients with who have relatives with autoimmune thyroiditis can have up to 50% of them positive antibodies in their bloodstream as well. And patients with other autoimmune conditions, such as type 1 diabetes, up to 40% can have anti-thyroid antibodies. Another interesting caveat here is that pregnant women can also have anti-thyroid antibodies despite having normal thyroid function. So it seems like not only patients with Hashimoto's, but some general people in the general population who do not have thyroid disease may also have the presence of these antibodies in their blood. There was a big study in 2018 looking at 12 years of follow-up of those individuals. So patients who do not have thyroid disease, but when we screen them, they have positive anti-TPO antibodies. And then they follow them through about a 12-year period to see what happens with these individuals, who is bound to develop hypothyroidism and who isn't. This is a study from Iran, and they looked at about 5,800 people, out of which 742 were found to have positive anti-TPO antibodies at the beginning. Not surprisingly, when we look at the two groups, those who had positive antibodies were more women than they were men, so 73 to 27%. It was closer to 50-50 in the group that were antibody negative. While both the T4 and the TSH were in the normal range, the TSH levels in the antibody positive individuals were statistically significantly higher than those who are antibody negative. Then they looked at the follow-up. So within 3, 6, and 9 years after the initial screening, they actually saw that there was 10%, 20%, and 10% at 3, 6, and 9 years of follow-up who developed hypothyroidism. So essentially, having anti-TPO antibodies actually increases your risk of developing hypothyroidism. And not surprisingly, because of autoimmunity, there was a less percentage of individuals, less than about 5%, who develop hyperthyroidism or overactive thyroid. When we look at the other cells, which are the T cells, those actually work to activate your immune system. They work to enhance the ability of B cells to produce antibodies, and they can also have a direct effect on the cells of the thyroid to destroy them or cause apoptosis of thyroid cells. This is depicted on the picture here, where you have this T cell, what we call helper T cell, that not only enhances the B cell activity to produce antibodies, but also enhances the ability of other T cells that essentially directly damage the thyroid cells. And all of this together then would lead to gland destruction and hypothyroidism subsequently. So then we go back to that nice architecture that I showed earlier in this slide, and then we look at some of the microscope slides of some of the glands that have been affected by Hashimoto's. On the top here, we see that this architecture now is completely lost, and we have all of these follicles here, but we have all of these nice purple kind of surrounding things. Those are all lymphoid cells, so B cells and T cells, essentially filling up most of the thyroid tissue. And some of the pink in between them, it starts becoming fibrosis, so more of a scarring in between the gland. And again, as things progress, then we completely lose this nice architecture, and all we see is just a whole bunch of cells, which are immune cells, essentially completing the destruction of the thyroid gland. Now, this doesn't happen overnight. So this is actually a gradual, slow process that takes time for all of these changes to develop. So when we look at follow-up over time, we have patients here that have normal thyroid function. And as we have progression of this disease state, then we see an elevation of TSH levels. Now, there is a period between being in the normal range and being overt hypothyroid is what we call subclinical hypothyroidism. So this is where we actually have a TSH level that's above the upper limit of normal, but yet when we look at the T4 levels, they're still within the normal range. Although if we look at it retrospectively, there's actually a slight decrease in the amount of free hormone level that we have available. Now, when we look at the rate of conversion between subclinical to overt hypothyroidism, it tends to be about 5% per year. And it seems to be more so the individuals who have positive anti-TPO antibodies that tend to progress into overt hypothyroidism. Interestingly, though, when you look at all comers who have subclinical hypothyroidism, up to 60% can actually revert back to a euthyroid state, especially if their anti-TPO antibodies are negative. So then we have to look at what proposed mechanisms of the autoimmunity are responsible for Hashimoto's. And it's very difficult for an autoimmune disease for us to be able to go back and determine the exact moment where things kind of got started. But there are some hypotheses that essentially suggest as to what kind of mechanisms lead to autoimmunity. The first one is what we call molecular mimicry. So in this hypothesis, it's basically if you have a virus or an illness that you're fighting, your body is bound to produce antibodies to fight that virus. If for some reason there's some similarity between the virus and a thyroid cell, that same antibody that is made to fight off the virus can also go in and attack your thyroid gland, just by happenstance. We also have the bystander activation theory, and that basically says that if you have infection directly within the thyroid gland, if you activate your immune system to fight off that infection, just by being in close proximity to the thyroid gland, then your thyroid gland will be affected and there will be antibodies generated to fight off your own thyroid gland tissue. And the last is what we call human leukocyte antigen expression. And human leukocyte antigen is essentially our way to regulate our immune responses, and every individual has a unique set of human leukocyte antigens. And in this hypothesis, what is proposed is that maybe individuals who are prone to autoimmunity have some sort of defect in the way that they express the leukocyte antigens, and that's what leads to autoimmunity. Again, this is just proposed mechanisms, but it's difficult to say for sure what kind of starts the whole process of autoimmunity. Then we have to think about what precipitates the autoimmune disease. And this is true for almost all autoimmune diseases. There's always going to be a combination of things that play a role. And when you have multiple insults at the same time, this is probably what leads to autoimmunity beginning. So for autoimmune diseases, we always talk about genetics, we talk about immune regulation, but we also talk about environmental causes that could contribute to your autoimmune disease. In the cases of Hashimoto's, genetics have actually been looked at quite broadly over the last 20 to 30 years. And there's been different papers showing some immunoregulatory genes that may be affected, some thyroid-specific genes that also may be affected, but also the way that we synthesize or that we make up thyroid peroxidase antibody or anti-TPO that may cause or contribute at least to the autoimmunity. In genetics, they always look at kind of the way that the disease clusters in families. And this is so true for other autoimmune diseases. And in endocrinology specifically, we also see that patients who have Hashimoto's have a higher risk of having other autoimmune conditions, such as adrenal insufficiency or type 1 diabetes, for example. And sometimes we have patients that have 2 or 3 of these autoimmune conditions in what we call autoimmune polyglandular syndromes. When we look at siblings, the recurrence risk is about 20%, but this is actually much higher in twin studies where they actually see between 30 to 60% concurrence rate of Hashimoto's in between twins. Now, there's increasing in frequency of Hashimoto's in other genetic conditions such as Down syndrome and Turner syndrome. So all of this together basically says that genetics has a big part of play here in the development of autoimmune thyroid disease. Then there's also papers looking at thyroid injury. So infection that we spoke about before, if you have an infection within the thyroid gland that can actually precipitate your autoimmune system to fight off your thyroid gland itself. Radiation can also contribute, and most of the data comes from the Chernobyl incident when they look at individuals who were exposed to high levels of radiation had higher levels of anti-TPO antibodies within 10 years after that. Now, there are certain medications that can also predispose you to have autoimmune thyroid disease. Just to name a few, amiodarone is one, lithium, and also immune checkpoint inhibitors, which are newer medications that have come around over the last 5 to 8 years that are used for different cancers. And we've seen patients with all of these three types of medications that develop autoimmune thyroid disease down the road. Stress is also mentioned in a lot of papers as well as some potential precipitating cause for autoimmune thyroid disease. Now, the data is limited and it's sometimes difficult to go back in retrospect and say, yes, stress is what actually led someone to have autoimmune thyroid disease. But they actually postulate that maybe cortisol may be mediating some of the cause of stress. So whenever we're stressed, our cortisol levels are going to be higher. And higher cortisol levels tend to decrease, at least relatively, your autoimmune system. So what basically this theory postulates is that if your cortisol levels are high during stress, then that actually gives way to some of these autoimmune antibodies to be able to activate themselves and fight off the thyroid. When I try to look at data that kind of shows what the implication of stress is in autoimmune thyroid disease, there was this randomized control trial in 2019, where they actually looked at 60 women who had Hashimoto's thyroiditis, and they broke them down into two groups. The one group, they actually had an 8-week stress reduction sessions, essentially, and then the other group did not. And at baseline, they looked at the anti-TPO levels, the anti-thyroglobulin levels, their TSH levels, and both groups actually filled in some quality of life questionnaires and some questionnaires looking at the amount of stress, depression, and anxiety. And after the 8-week of the study, they actually compared both groups. And the findings were actually quite interesting. So the group that actually had the 8-week session for stress reduction, based on the questionnaires, they had higher quality of life, but also less stress, depression, and anxiety based on the questionnaire responses. And then we went back and looked at the anti-TPO antibody levels and anti-thyroglobulin levels in the bloodstream. And anti-thyroglobulin was actually statistically significantly less in the patients that underwent the stress reduction session. And while not statistically significant, there was also lower anti-TPO antibody levels. Now, when we look at the TSH levels, this didn't really change how much TSH there was, but at least it seems like stress reduction did have an impact in the number or at least level of antibodies in their bloodstream. There's also a lot of data looking at female sex because, again, women tend to be more predisposed to Hashimoto's than men are. And the initial studies were looking a lot at estrogen and see maybe higher estrogen levels had something to do with autoimmunity. However, when we look at women only, there's actually a higher incidence of Hashimoto's in older women that are postmenopausal, that per se have low estrogen levels, compared to younger women. So that's when the estrogen idea actually kind of was put to the side. And now, more recently, they're looking at X chromosome inactivation. So women have 2 X chromosomes, and typically one of those 2 X chromosomes gets inactivated. And there's maybe some thought that maybe the inactivation doesn't work as well in certain genes, and that's what predisposes some women to autoimmunity. But again, some of the data is still preliminary. Pregnancy is another condition where actually there's an increased incidence of Hashimoto's disease, especially in the postpartum period when we call postpartum thyroiditis. And the thought here is that during pregnancy, the autoimmune system tends to kind of slow down a little bit to make sure that there's no autoimmune responses to the fetus. But as soon as the pregnancy is over, then there's this rebound immune function. And that's where we think that maybe some of those antibodies to fight off the thyroid gland get activated and then Hashimoto's ensues. Iodine also has a lot of data showing the effects of iodine deficiency, but also iodine excess in the onset of Hashimoto's disease. And this is a review in 2019 by Wong and colleagues, where they actually try to figure out, so what is the sweet spot of iodine consumption per day? So they realized that iodine consumption that is less than 100 micrograms per day, what we call deficiency, actually increases your risk of developing autoimmune thyroid disease. But if you have too much, and that seems to be somewhere around maybe 400 to 500, then your risk increases exponentially as well. So typically what we say is between 150 to 200 micrograms of iodine per day are probably the sweet spot to have. And if you have too much or too little, then that predisposes you to having autoimmune thyroid disease. It is not difficult to get enough iodine in our diet. And as we can see on the left here, this comes from the National Institute of Health. Most of our foods have some sort of iodine supplementation, especially iodized table salt. So it's not difficult for us within our regular diet to be able to have enough iodine content on a daily basis. On the right, there's a table here showing the dietary needs for individuals from birth all the way to adulthood. And for adults, again, around 150 micrograms a day is probably sufficient. We did need more during pregnancy and lactation, but typically your prenatal vitamins will have enough iodine for that. Then we look at what associated factors have been found with Hashimoto's thyroid disease. So there are some associated diseases such as allergic rhinitis, prolactinomas, and as previously mentioned, Down and Turner syndrome that have had some sort of correlation with Hashimoto's disease as well. And environmental and nutritional factors. And this is where the data gets a little bit more difficult to interpret. So if we go back and see some of the epidemiological studies, we've actually found that smoking and alcohol, for some reason, seem to have a protective effect against Hashimoto's thyroiditis. Now, this is not me advocating for alcohol and smoking consumption, but this is just what the data has shown in some of the epidemiological studies. There's also some data looking at selenium deficiency and vitamin D deficiency as contributing to Hashimoto's thyroid disease, but it seems to be more the replacement of deficiencies that are beneficial in reducing antibody levels. There was a systematic review that was just published earlier this year, but they actually took some of those studies on nutritional interventions for the treatment of Hashimoto's, and they try to look at all of that data and kind of come up with some conclusions and say, what do you think works and what doesn't? So there's a lot of data looking at gluten-free diets in Hashimoto thyroiditis. And there is something to this because Hashimoto's and celiac disease tend to coincide in about 2 to 8% of patients. Again, one autoimmune condition can lead to other autoimmune conditions as well. Now, what happens with untreated celiac disease is that it makes absorption of levothyroxine treatment to be less effective. Hashimoto's patients have also been found to have a higher prevalence of what we call non-celiac gluten sensitivity. So these are patients that don't have the antibodies for celiac disease, but don't seem to react as well to gluten diets. Now, gluten restriction per se hasn't been consistently shown to improve TSH levels, free T4, or free T3 levels. So hormonally, it doesn't seem to do much, but there is some data showing that a gluten-free diet might decrease the amount of anti-TPO and anti-thyroglobulin antibody levels in the blood. So basically, after looking at all of those studies, this systematic review basically said that we don't have enough data to recommend gluten-free diet across the board to all patients with Hashimoto's, but maybe those who do have some symptoms suggestive of celiac disease, there might be some benefit with that. Lactose elimination has also been looked at, and there was one study that showed that 76% of patients with Hashimoto had some sort of degree of lactose intolerance. Now, lactose is a common component of levothyroxine formulation. So if you do have lactose intolerance, then your treatment is actually going to be more difficult because your absorption is going to be limited. Now, when they look at the new diagnoses of Hashimoto, so patients who have not been treated yet, and they put them on a lactose restriction, there's actually been no effect in the improvement of thyroid hormone levels or antibody levels. So it seems to be only at the absorption level of levothyroxine that lactose restriction may work. We looked at selenium as well, and there's some low quality evidence saying that selenium supplementation may reduce the antibody levels in your bloodstream. There's some other studies looking at black cumin or Nigella sativa, and they do show that maybe some improvement in antibody levels, but there seems to be more of a reduction in body weight. And there is some evidence showing that maybe decrease in body weight may help improve your autoimmune condition. But again, it's difficult to conclude that for sure. And then we have vitamin D, that in select studies show that vitamin D deficiency and subsequent supplementation may have an improvement in the antibody levels in your bloodstream. And this vitamin D signal happens to show up in Hashimoto's, but also in some of the other autoimmune conditions as well. So I always go back and try to think about, so what's the rationale behind some of these nutrients and how does it work physiologically? There is some physiological papers that show that selenium is a cofactor for the deiodinases that help convert T4 to T3. So maybe that's the benefit where it works there. Zinc as well seems to help in the T3 receptor activation. Iron may help in TPO reactions. And vitamin D deficiency, as mentioned, does correlate with autoimmunity. So replacing vitamin D may be beneficial. However, when we look at all of these studies that have been published on nutritional treatments for Hashimoto's, each study tends to have a different population with different exposures and sometimes even different thyroid statuses. So not everybody is Hashimoto. Some people have other sort of hypothyroidism. The studies also tend to be small, so less than 100 people per study. And there may be other factors that may influence their findings. So there was one paper that I looked at that was reviewing gluten restriction in Hashimoto's, and they said, yes, it works. But when they looked at the data closely, it seems that it wasn't necessarily the gluten restriction, more so than the vitamin D supplementation that had a positive effect in antibody reduction. Now, Hashimoto, as we know, is a very heterogeneous disease. There's a lot of variability between patients. So sometimes it's difficult to apply all of these nutritional supplements and say that it's going to work across the board. It seems to be very select populations that do benefit from it. Now, how do we diagnose Hashimoto's? And we do rely heavily on our laboratory tests to establish our diagnoses. And that's because symptoms of hypothyroidism can be very non-specific. Now, if we look at this table and we know that hypothyroidism does affect every single organ in our body, and some of the symptoms that patients report, yes, could be attributed to hypothyroidism. But one of the things that I do as an endocrinologist is I always think, okay, let's say that it isn't the hypothyroidism. What else am I missing? What else could be causing some of these symptoms? Because if I am treating hypothyroidism and the symptoms don't get better, then I want to make sure that I am not missing something else that could potentially be addressed. So serum TSH levels are the initial test. And if we do have a TSH level that is high, then we tend to repeat that along with the free T4 level to ensure that the free T4 level is low and confirm my diagnosis of hypothyroidism. Now, there's low utility of sending anti-TPO antibodies at first with the initial diagnosis, because most of the cases of hypothyroidism are going to be due to autoimmunity, more than 90%. So it doesn't, if you are diagnosed with hypothyroidism, there's little utility of knowing that you have anti-TPO antibodies. However, in those patients that we pick up at the subclinical hypothyroid phase, that means your TSH is high, but your free T4 is normal, then having an anti-TPO level might be useful because this can help us determine the risk of developing overt hypothyroidism in the short to intermediate term. And that may be so that we can do follow-up more closely or even start treatment preemptively as well. Now, in patients who have high anti-TPO antibodies, but a normal TSH and a normal free T4 and free T3, then they don't require treatment. Again, if we go back, there's about a 20% of the general population that has normal thyroid function, but do have presence of antibodies in their system. Now, if your TSH is slightly elevated, and we usually use a threshold of about less than 10, then repeat testing should be done within 3 months to see which way your TSH is heading, and maybe doing a T4 level as well to see if you're truly hypothyroid. Now, if you do have overt hypothyroidism, that means your TSH is high and your free T4 is low, then treatment then would be recommended. And the way that I summarize this here is essentially what I just mentioned. So we start with the TSH. If your TSH is normal, then no treatment needed. If your TSH is high, then I actually repeat that with a free T4 level. And if both of those came back to normal, then no treatment needed at this time. Now, if your TSH is high and your free T4 is low, then you are diagnosed with hypothyroidism. At that moment, you can begin treatment. Now, if your TSH is high and your free T4 is normal, this is what we call subclinical hypothyroidism. If your TSH is more than 10, then this is kind of the threshold where we say, well, this might be a little bit too much and we can consider treatment. Now, if your TSH is less than 10, this is where I think anti-TPO antibody levels may be useful, because if you are antibody TPO positive, that means that you have a higher chance of developing overt hypothyroidism, and it may be worth treating at that point. Now, if your anti-TPO is negative, then at that point we consider the symptoms present. And if there's a lot of symptoms suggestive of maybe hypothyroidism, then a short course of treatment could be tried out and see if the symptoms improve. In Canada, there are 3 different medications that are available for the treatment of hypothyroidism. So the more commonly known is levothyroxine or Synthroid or Troxin. We also have liothyronine, which is Cytomel, which is T3, that can be used in combination with T4 in a certain subset of people. And we also have desiccated thyroid extract available, and Erfa Thyroid is the one that's available in Canada. Although there are certain compounding pharmacies that can also generate desiccated thyroid extract, and this comes from desiccated thyroid glands from animals. Now, once you begin treatment, then you will need close follow-up to ensure that your TSH remains in the normal range. And how frequent that follow-up is really does depend as to what formulation of medication you're using. It may be less frequent for levothyroxine, but if you're using some sort of combination therapy, then you will want to make sure that you follow up closer to ensure that you always keep your TSH within the normal range. So to summarize, Hashimoto thyroiditis then is the most common cause of hypothyroidism in iodine-sufficient areas of the world, as it is North America. It is characterized by lymphocyte or white blood cell infiltration of the thyroid tissue and then subsequent damage. The onset is gradual, and antibody presence, such as anti-TPO or anti-thyroglobulin, increases the risk of developing overt hypothyroidism over time. Now, there are certain causes and contributing factors, which include genetics, thyroid injury, iodine consumption, as well as environmental and nutritional factors that play a role. Now, the treatment then focuses on the correction of hypothyroidism with the goal of normalizing our TSH levels to ensure that they're kept in the normal range. So that was just an overview of Hashimoto thyroiditis. I hope that was useful. And I think now we'll take some time to answer some of the audience questions going forward. Thank you very much for your attention.
Thank you, Dr. Franco Lopez. That was the most interesting presentation, and I really like the amount of detail that was in there. Anista will now read your questions from the audience for Dr. Franco Lopez. Please remember, use only the Q&A feature located at the bottom of your screen for your questions to the presenter. We will not respond to questions from the chat feature or from emails. So, Anista?
Yes, thank you, Dr. Franco Lopez, for that wonderful talk. I found it very informative and easy to digest. So we received a handful of questions during the talk, and I'm sure we'll get more in a few minutes. So the first question is from an attendee with Hashimoto's for several years. And at the time, they found a nodule on one side of their thyroid. How frequently should this be checked out? And should this be seen by an endocrinologist or a family doctor?
Yeah, so thanks for that question. So thyroid nodules are common. So up to 50% of people will have a thyroid nodule at some point. The frequency of follow-up of thyroid nodules does really depend as to what the characteristics of that nodule are when they initially find it. And there is a criteria that we use on ultrasounds for thyroid nodules that essentially give us the risk of this nodule being cancer, which is essentially what we care about. That's called the TIRADS criteria. And there's certain different features that we look at on thyroid nodules that tell us, is this a high-risk nodule versus not? And that includes how big it is, so the size, how dark it is on the ultrasound, whether it has calcifications within it, whether it's solid or it has some fluid-filled components. So it really does depend as to what the risk of cancer this is based on the imaging guidelines. So you'll have to kind of review that ultrasound. And most of the ultrasounds nowadays, because these guidelines were published in 2017, so most of the ultrasound nowadays will have that criteria outlined. But if you're not sure, then you can have a repeat ultrasound and then ask your healthcare provider to ensure that they include that criteria. Without knowing those details, it's difficult to say how long it should be followed up on, but there is specific things that they can look on ultrasound to give you that answer.
Great, thank you. And the next question is, how long is it normal for a flare-up to last?
Yes, so that's a good question. I don't know that there is a normal for a flare-up to last. We do know that Hashimoto's does have this, this called waxing and waning effect, where sometimes there's more autoimmune activity versus other times, and there can be a myriad of reasons why that happens. Stress is one of them that keeps being quoted in the literature as the reasons why sometimes your Hashimoto may flare up. So I don't think I can give you a specific timeline as to what's normal. But what's more importantly, though, is, when you have Hashimoto's, is to ensure that your thyroid hormone levels are normal, because that's what's going to impact your quality of life. It's how much thyroid hormone you have available. So what I would say is, whether it lasts a long time or a little time, as long as you have your thyroid hormones checked out and you have appropriate replacement for them, I think that's probably going to make the biggest difference. But when we look at the literature, there's really no way to tell what a normal time of a flare-up would be.
Right, thank you. Another question asks, have relationships between Hashimoto's or other diseases of the thyroid with the thymus glands or the tonsils been reported, since both nearby glands produce T cells too?
Definitely. So I don't know of any literature looking at the tonsils specifically, but the thymus gland is an interesting one because it does pop up every now and again, especially with hyperthyroidism with Graves' disease. So when we have antibodies that actually activate the thyroid gland in Graves' disease, there's been some association with thymus gland hyperplasia or enlargement of the thymus gland in hyperthyroidism. When it comes to Hashimoto's, I haven't seen many per se in my practice. And when I did some of the reading for this talk, I didn't come across of any thymus enlargement in Hashimoto's, but I have seen it, and it is published in the literature for Graves' disease, which is hyperthyroidism. The tonsils I have not seen.
Thank you. Another question asks, I was wondering if there have been any studies on histamine intolerance and leaky gut syndrome as how it may impact Hashimoto's.
Yes, so there is some data on the concept of leaky gut. When I went through it, and I didn't present it here just because it gets very convoluted, very complicated the way that they explain it. But it seems to be with absorption of minerals, and selenium and vitamin D are two that are mentioned over and over again, and how that may impact the level of antibodies in the bloodstream. As far as histamine, I didn't come across of any of that myself, but I personally don't do research in that area. So there may be some literature out there, but I'm just not familiar with that one. But the leaky gut does come over in the literature as well. And it's difficult to say, is it an absorption issue? Is it an activation issue? But there are people looking at that, and we may have an answer kind of in the coming years, but there is something to that, it seems.
Great, thank you. The next question is it common for Hashimoto patients to need medication changes with seasonal changes?
Certainly, yeah. So, the patients with Hashimoto's rely on your replacement therapy for the amount of thyroid hormone that's available. And with seasonal changes, your metabolic rate may change so that you are requiring more of that thyroid hormone. And because you don't have an active thyroid gland that can produce any fluctuations in your metabolic rate, so you're either going to have some times where you might need a little bit more therapy and maybe need a little bit less. Levothyroxine replacement, for example, is very tied to weight, to body weight, both lean body mass and total body mass. And so if there's fluctuations in weight across the year, then that might also affect the amount of thyroid hormone replacement that you need. So yes, definitely that's something that we see.
Thank you. We received two similar questions about iodine intake. So how do we know if we're getting enough iodine?
Yeah, so in North America, it's very difficult to be iodine deficient. I think you have to work actively to avoid iodine from your food to be able to say, yes, you're iodine deficient, because it's present in like a lot of the things that we consume on a day-to-day will have some sort of iodine in it. And just by having a couple meals a day, you probably have enough. If you use any salt, most of it has iodine supplemented on it. So you're going to have enough just by using just like a quarter teaspoon of that. So in North America, it's very, very hard to have a deficiency in iodine. You have to actively work at it. Now, iodine excess, I have seen from patients of mine, especially with Graves' disease, that all of a sudden start taking supplements that without them knowing have a lot of iodine in it. And as we saw, it doesn't take much to go from 150, which is the regular dietary intake, to cross that 400 to 500 microgram threshold. And if you're taking additional supplements with extra iodine, that might actually tip you into that threshold. So in the cases of Graves' disease, for example, too much iodine can actually make your gland more active because you have more substrate for it. But I would say to have iodine deficiency, it's very difficult in North America. But make sure that if you are taking extra supplements, that you are aware that they don't contain too much iodine, because sometimes it does get advertised that, oh, here's an iodine supplement, but it just might be too much.
Thank you for the detailed response. That was great. The next question is for Hashimoto's with initially normal T3, T4 levels, but high antibodies. if thyroid hormone treatment greatly reduces symptoms but suppresses TSH, are there potential long-term problems with hormone supplementation?
Certainly. So, if your free hormones are normal and your TSH is normal, even if you have high antibody levels, I wouldn't advocate for treatment right at that point, because again, we don't know if you probably have a higher chance of developing hypothyroidism, yes, but whether or not your antibodies are present because you are going to, or just because you're one of those 20% of the general population that are going to have some antibody activity, it's unclear. Having too much thyroid hormone, and that would be by reducing your TSH, there is some data that maybe has some effect down the road, especially with osteoporosis, and there's some issues with cardiovascular disease that some studies also mention. So typically, I don't advocate for suppressing your TSH if you don't have to. And so I would probably say a normal TSH level, as long as you keep it within that limit, is probably okay. Now, the reason I say if you don't have to is because patients with thyroid cancer, we do have specific reasons for wanting to suppress the TSH, and that has to do more with cancer recurrence, more so than keeping a normal thyroid hormone range. But in regular Hashimoto's, if you don't have, if your thyroid hormones are normal, then I wouldn't advocate for treatment. But if they're not, then I would just say treat it so that your TSH is in the normal range. Some people tend to feel a little bit better with the TSH in the lower end of normal, but as long as you keep it within that normal range, I think it's probably safest.
Thank you. So this patient describes having an itching sensation as her flare-up, leading to round-shaped hives. Do you have any suggestions as how to get some relief from this chronic condition?
That's interesting. I don't think I've seen any of my patients with a similar reaction. Yeah, difficult to say. I don't know if I have any wise advice here as to how to do that. I guess if there's some sort of itchiness and hives that develop to it, I'm presuming that must be some sort of histamine mediated process here. So I would tend to say it'll be, yeah, I haven't seen it before, so I don't know if I have any wise answers, but maybe speak with your healthcare provider and see. Yeah, I don't think I have a good answer for that one.
Right, thank you. So someone asked, can Hashimoto's ever go into remission?
Interesting question. So I wouldn't say that. So Hashimoto's is an autoimmune condition. Sometimes it does kind of lower the activity of the antibodies, and the antibody levels can come down. However, it depends as to what stage of the disease process you're in. If it's at the beginning where kind of things are just getting started and your antibody activity kind of lowers down, then yes, maybe you won't have as fast of a progression. However, if it's to the point where there's already some damage to the thyroid gland and there's some fibrosis or scarring in the thyroid gland, even if your antibody activity reduces, you still already have a damaged thyroid gland that's going to need thyroid supplementation to be able to maintain your required level of thyroid hormone. So there is, if by remission we're talking about antibody activity, then there is some waxing and waning in Hashimoto's, but it depends as to what degree or where in the disease process you're at, as to whether you're going to be able to come off of medications altogether. The further advanced you are, the less likely is that you're going to be able to come off of therapy.
Right, thank you. The next question asks, is it common to fluctuate between hyper and hypothyroidism throughout the year?
Oh, so that's a good question. I don't think it's common, but it is seen sometimes. There are patients that have antibodies that both, activate the thyroid gland, such as in hyperthyroidism, and inactivate the thyroid gland, such as in Hashimoto's. So I have seen a couple of my patients in my practice that did present that way with hyperthyroidism at first, and then hypothyroidism, and then back to hyperthyroidism again, which is, it's not the norm, but it is possible. Sometimes what we do see is that there are patients who present with hyperthyroidism at first, and just more of a component of the thyroiditis. So as the gland becomes inflamed, then you have all of this release of the stored hormone from the colloid, and that increases your free T4 and free T3. Patients become very symptomatic with that and present to us. And then as we follow them along, we figured out that yes, in fact, it's actually Hashimoto's, and you have just this inflammation and destruction of the gland at first. And then you go into this hypothyroid phase because you essentially use up all of that hormone, but your gland loses the ability to produce more. And that's when you go into that hypothyroid phase that you continue on going forward. But that's more of a feature of thyroiditis. But I do have a couple patients that it's rare, but they do seem to have both antibodies to activate and also inactivate the thyroid gland. So it can be possible.
Thank you. I think we have time for one more question. So is molecular mimicry considered the leading proposed mechanism of autoimmunity in Hashimoto's?
So I put them in that order just because that's how a couple of the papers presented it. I don't know that if it's the leading, but it is one that comes across not only in Hashimoto's, but other autoimmune conditions. So if you read about adrenal insufficiency, if you read about rheumatoid arthritis, it seems like this concept of molecular mimicry, this does come across in different studies for different autoimmune conditions. So I guess it's the more generalized across the different types of autoimmunity. Whether it's the leading one for Hashimoto's, it's hard to say because there are researchers looking at it from different directions, and most of them do find some sort of connection. So I wouldn't want to dismiss the other two, but that one does come across different types of autoimmune conditions.
Okay, great. Thank you so much, Dr. Franco Lopez, for taking the time to answer all our questions in great detail. And thank you to the audience for the great questions. So that wraps up our Q&A.
Thank you very much, Anista. I'd like to thank Dr. Franco Lopez for giving us his presentation. We would like to show our appreciation by awarding Dr. Franco Lopez a copy of Dr. Bianco's book, Rethinking Hypothyroidism.
Thank you very much.
I would like to thank our webinar team for making this education event a success. This webinar was supported by a grant from Pfizer Canada. I'd like to mention that if you have spare time and would like to volunteer to help others with thyroid disease virtually from home, please call us on our helpline at 1-800-267-8822 or email us at info@thyroid.ca. You can also assist us by becoming a member of TFC or making a donation by visiting our website at thyroid.ca. As you exit the session, please take a moment to complete our short survey. You will also have an opportunity to enter your comments. This will help us improve our future webinars. Our next webinar will be on May 14th. Dr. Jesse Pasternak will be speaking on ultrasound-guided thermal ablation of thyroid nodules. It's a long one. All of us at the Thyroid Foundation of Canada hope to see you again soon. We hope to see you and we hope you and your families are well and keeping safe. Thank you very much.
All right, thank you for having me.
Thank you, Dr. Franco Lopez. Bye, everyone.